My name's Adam. And just in case you guys are in the wrong session, we're going to talk about solving wicked problems across the care continuum. And I'm going to go straight into the topic. What we're really going to talk about today is how to leverage digital transformation to support a sustainable integrated care model that adopts a person-centered care approach to strengthen the care ecosystem for a healthier SG, while trying to address the quadruple aim of improving population health, reducing cost of care, improving the patient's experience, as well as provider satisfaction. Now, you might be thinking that there's a lot of buzzwords in this very, very short abstract. So I'm going to take you all through a very quick holistic journey and see how all these different concepts actually weave together. Before that, as I understand, if you guys have any question during the lecture, you can actually post them using Slido. Do kindly scan the QR code and submit the questions, and there'll be someone to help collate that. The same QR code would also be shown at the end of the presentation. So if you missed it here or something goes wrong with your phone, you can scan it again later. So with that, I'm going to move into the lecture. Now, as I mentioned, it seems to be a lot of buzzwords in a very short abstract. So we're going to go on the same page because certain people have, as I go through teaching some of these concepts on a daily basis, people have different interpretation of these topics. So we're going to standardize them before we move on. So first thing first, the Holy Grail. What are health systems around the world trying to achieve? Okay. With that, I need to introduce to you the IHI, the Institute of Health Improvement Triple Aim Framework, which is an approach to optimizing health systems performance, which include improving the patient experience of care. These, of course, include quality and satisfaction, not just important to be well, but be happy as well. Sometimes a little bit difficult to achieve both, but we try. Of course, improving the general health of the population and reducing cost. It would be a lie if any health system out there tell you we don't care about cost. Because at the end of the day, someone has to pay for it. So we have to control costs and make sure it doesn't balloon. And at this point, you may be asking, say, Adam, that's only triple aim. How about the quadruple aim? So for those who are familiar, there's actually a fourth one that came out, which is improving the provider's experience. This is something I like to tell people all the time. Please take care of me. I'm human too. So when I'm in delivering care, please do not abuse me. And you see more and more of these voices coming out. Say, okay, let's take care of healthcare professionals as well. So this is the Holy Grail, if you will. All health systems, be it in Singapore, around the globe, we want to achieve the quadruple aim. And another concept I'd like to talk about would be the continuum of care. Now, what is the continuum of care? It is a concept involving an integrated systems of care that ideally guides and tracks patients over time through a comprehensive array of health services across all levels of healthcare, be it primary, acute, tertiary, step-down, etc. It doesn't matter. Okay? And this is usually a primary care led approach where it is patient-centered. We'll talk a little bit more about patient-centered later. So I have this diagram here to try and articulate what the continuum of care is. Basically, all sort of health services that you have, prevention and wellness, all the way to palliative. Okay? So this is very simplistically the continuum of care. Now, to articulate it further, we have to go deeper and understand what is the difference between integrated care and population health. Because people tend to get these two concepts mixed up. They're very close, interrelated, but not exactly the same. Now, integrated care, as mentioned earlier on, is care that is planned with people who work together. So you have a care team that understand the service user and their carers, put them in control, and coordinates and deliver services to achieve the best outcome. So basically try to guide them along the healthcare system. This is integrated care. Population health, on the other hand, it is one type of integrated care. There's many models out there. Today we're just going to talk about population health. So a population-based approach to integrated care delivery, scoping review of clinical care, and public health collaboration. So usually, okay, population health will rest on 4 pillars: your chronic care management, of course, quality and safety, public health, and health policy. So this is the very quick 30 seconds holistic difference between integrated care and population health. If I were to go a little bit further and articulate it, based on this diagram, you can see the XY axis, population, individuals, this is the units of care, focus of intervention, care services, health improvement. This really is towards healthcare. It's reactive. You wait for the patient to be sick, then you try and take care of the patient. Health improvement, move towards health. Okay, so that is the focus of intervention. And similarly, the unit of intervention, populations and individuals, when you're doing public health, for example, you actually broadcast the message to a wider audience, bigger audience. So your individual effort is multiplied. This is what we call population. You identify the relevant population, if you will. Can be multiple populations. So using this diagram, we can see that both integrated care models and population health systems, they are moving towards populations in general. But if we look at the definition, integrated care models, which has many different models, it's coordination of care services for defined groups of people, whereas population health is improving health outcomes across whole population. So you can see that this is really towards healthcare, and this is really towards health. But in order for you to implement either model, you must have certain common infrastructure in place. You must have a continuum of care model, or else it would not work. You simply can't have good outcomes implementing such measures. So with that, if you put it into the Singapore context, the recent policy of Healthier SG is a form of population health. And at this point, you'll be asking, so Healthier SG, you're trying to target the entire population of Singapore. Isn't that a bit ambitious? Yes and no. You can have subpopulation within the entire grand scheme of things, and you have different clinical interventions, health interventions, accordingly, of course, with your different providers, etc. So this is really what it is. And as the name implied and suggested earlier on, we are moving towards health. We are moving towards preventive care. Why? Because you can't just keep providing health care. It is not sustainable, okay? No matter how much money you throw in, people don't take care of themselves. Then they'll go sick, and it's a vicious cycle. So Singapore, we're trying to move towards this model, Healthier SG, which is actually moving the population in general towards preventive care, towards a healthier SG. So this is where you can start to put things in the context. And to do that, if you map it back to the Singapore healthcare system, now we have 3 clusters. Each cluster have their own ecosystem, if you will. These are the integrated care model, right? And above of that, you're trying to put in care services. The Singapore term that we invented is right siting. It's a Singapore term. You can't find it anywhere else. And I think it's a wonderful term because it really is a term that describes how you shift the patient to the correct health services. So this is Healthier SG. So we talk about population health. And to do that, we need something what we call patient-centered care. Now, let's take a look at what patient-centered care is, because sometimes when I talk about this concept, there are a lot of misunderstanding on what it entails. So instead of medicine defines patient-centered care as providing care that is, number one, respective of and responsive to individual patient preferences, needs and values, while ensuring that the patient value guides all clinical decision. Now, it is not giving the patient whatever they want. Some people actually come to me, oh, it's patient-centered care, so you should give me more cough medication. You should give me MC wherever I demand. No, that's not patient-centered care. Some of these requests sometimes is actually medically not ethical, okay? What it really is, some characteristics of patient-centered care is, as mentioned earlier on, it respects individuals' preference and diversity, including the rights to comment, ask questions, and make complaints regarding the care they receive. So they have a stake, okay, in making certain decisions. and you recognize patients' needs and respect theirs or their family. Very important aspect when we talk about patient-centered care, and I'll articulate why later. Right to say, or having a say, and making health decisions and choices when we are planning the care and treatment. So in other words, patient-centered care is really about treating a person receiving healthcare with dignity, respect, and involving them all on decisions about their health. So if a patient actually refuse treatment, and it's actually their right, you can't really force them. Of course, these days when we talk about patient-centered care, when we're moving to healthier FG, there are terminologies that describe it as person-centered care. Basically because we can have participants of health who are not sick yet. We're trying to move them towards preventive care. So with that, I'd like to introduce to you 8 dimensions of patient-centered care. This is a very important topic, a very big topic. We're just going to skim the surface today. Of course, patient preference, as we mentioned earlier on, very key cornerstone. Emotional, physical support, that need not be explained. Of course, social as well. Social is where the family and friends comes in. What a lot of people don't understand is that when you take care of the patient, the main caregiver is actually family and friends. So when you discharge a patient, I don't know whether some of you have this experience of being discharged. When you're discharged, most probably you're a little bit confused, groggy, not in the right mental state, and then you have nurses or the medical doctor come and give you instructions. I don't know about you guys, I can't remember any of them. I'm just simply not in the correct mind frame. I just want to go home. Okay? This is where it's important when you design interventions to include family and friends, because they will be the one who's going to take care of the patient. So if someone, a patient is not taking their medication, look at it, it's a child, maybe send the alerts and notifications to the parents. Is it the elderly folks not taking medication, right? Send the alerts and reminders to the child. So as like that. Now, access to care is also equally important. I work in certain countries where we tell people eat healthily, exercise, but there's no gym nearby. The overall temperature is 50 degrees Celsius, okay, and they eat meat on a regular basis and drink soft drinks. So when we keep telling people that, hey, you have to exercise and eat well, and they sometimes look at me, Adam, how? I don't cook, I eat out on a regular basis. The options I have are all unhealthy food, American-sized food, and everywhere it's soft drinks. So when we prescribe care, we have to look at environmental as well. Okay, and of course there's also continuity and transition, coordination of care, which I'll touch a bit later when I weave in all the concepts. Now I'll bring you, ladies and gentlemen, back to this continuum of care diagram, this simplistic diagram. And now if you were to talk about patient-centered care, what we really want to do is to enable patient-centered care across the entire continuum of care. Now that is an extremely tall order for those of you who work in a healthcare system. To do that, you must use technology. Digital is what you need. You need to have it as an enabler. So the next topic I need to set all of us on the same page is on digital transformation, because people get mistaken what digital is. The thing is just technology. Technology is actually the least of your concern when we do digital transformation. Now, when we talk about digital, there's usually 2 terms that comes very frequently. One is digitization, one is digitalization. You may have come across popular literature that tries to articulate both terms as synonyms. They are not the same thing. So allow me to demystify that. Digitization is defined as the process of changing from analog to a digital form. That's it. I'll articulate more later, but that's it. Really going from analog to digital. Digitalization is defined as the use of digital technologies, which is here, to change a business model, provide new revenue, value producing opportunities. So it's a process of moving to a digital business. So what it is digitization is really about tools. The tech that you can buy, anything you can buy with money, most probably these are tools. Whereas digitalization, this will be your strategy and operations. If you're trying to fix healthcare with tech, and you just throw tech in, It's just benefiting tech providers. That's it, right? You have to actually have some effort put in place to change your processes, workflow, etc. So while there is no digitalization without digitization, the two terms are not the same. And this is very important concept because you end up saving yourself a lot of trouble when you talk to your tech partners, okay? So what does digitization entails then? You know, when I talk to hospitals in Singapore, Ministry of Health, because we do projects with them, they will say digital hospital, paperless, HIMSS level 6, 7, latest equipment, blockchain, analytics. This is marketing buzzwords, okay? If today you come across that situation again, tell them, whoa, whoa, whoa. I'm not really interested in your basket of digital distractions. The tools aside, let's look on the important stuff first. To articulate what digitization, although I give you the definition, it takes some time to absorb them. Let me give you some example. And I'm going to use the traditional thermometer, mercury-based thermometer. If I were to digitize this thermometer, it simply is a digital thermometer, no big deal. You can get this from any online store and use it in the traditional method. No change in processes or workflow. If I were to digitize it, I'll give the example of a patient, in this case a baby, with some tech, temperature monitoring patch. So what this does is, in all some of the medical technical jargons, you can actually continuously get data from the patient and over to an application, regardless of what tech you want, IoT, Bluetooth, doesn't matter. But with this is, once you have baseline data, you keep collecting data, put some AI onto this, you can start to have spike in trends. So it's this fantastic tech piece. But that's not the important thing to patients. Patients are not impressed by your tech. It's actually the patient's comfort. In this case, for those who have worked in a hospital before, the nurse don't have to periodically upset the patient, wake up on an hourly basis and check the temperature. Let the patient sleep, be it a baby or not. The nurse themselves, they don't have to put down whatever they're doing. They're very, very busy people, just to take temperature on a regular basis. And if you translate this into a COVID situation, everybody's happy because you don't have to go near the patient. We love them, but you don't want to die too. Okay? So this is digitalization. But here's the thing. Nurses do more than just taking temperature, don't they? So you only automate workflow on one silo bit. Is it important? Yes. Is it great? Yes. But in the grand scheme of things, not enough. What we want to do is digital transformation, which is a whole-scale, system-level usage of technology to do a lot of this. Okay, so you modify existing clinical processes, you optimize existing resources, culture, and patient experience. Of course, also provider, don't forget that. So if I were to go further, over here, we're optimizing processes. And over here, we're optimizing human experience and systems interaction. This is what set healthcare apart from a lot of different industry. In a lot of industry, if you set the processes right, full stop, that's it. The human aspects, they have limited exposure, be it F&B or whatever, just very controlled setting, limited period. Healthcare, unfortunately, no, okay? And the experience, remember, go on the continuum of care, could be a long journey. So this is a lot more difficult because we are dealing with human beings, okay? Giving that example, a lot of people sometimes still get, say, Adam, I get what you're saying, but I can't really articulate it yet. So I have another example. You guys might be familiar with this diagram. They use it a lot for equality-related lectures. So down here, and go with me, these three kids wants to watch baseball. Okay, this is what they want to do, and there's a barrier. Okay, this is the challenge they have, and they're given tools. In this case, 3 crate boxes, evenly distributed. Okay, a lot of hospitals, healthcare systems right now do this. We call it a process improvement. It's function-centered. Remember the diagram? Processes, the humans, and system. Think of it in your clinical setting right now. Everybody gets the same amount of resources regardless, right? It's very fair. Or if you get nice networks, computers, regardless of whether you need it or not. Or you need more. Doesn't matter. Equality, everybody gets it. Is it great? Absolutely. Can we do more? Absolutely too. So, we go a little bit further and we go on the human-centered aspects, be it provider or patient. We say, hey, let's redistribute this a little bit in context to your actual needs, be it clinical, administrative. Now, is it great? Fantastic, because not everybody is happy. But in digital transformation, what we want to do is to remove the underlying barrier to begin with. And we do that with systems level innovation, which is what this topic is going to talk about. Okay? Of course, all stages are equally important. After this lecture, you don't go back, hey, Adam says we need to do this, so whatever you guys are doing right now, not good enough. I'll get a lot of death threats, okay? That's not good. So, which is exactly all the above actually tries to set the stage of what I'm trying to articulate for the next 20 minutes, I guess. So, all of you who have worked in a healthcare setting, have you ever had a situation where you fix something minor, you break the entire healthcare system? Very common. I do process improvement in my department. In the grand scheme of things, things doesn't work out. Or maybe some never heard of it. Think of it from the patient's perspective, not the provider perspective. Okay, we have a lot of times when we do improvement, we do departmental improvement. Then maybe you even do it a hospital-wide improvement. But again, remember, when you go across the continuum of care, it's much more than that. And this is normal. When we fix something, it's usually within our preview of authority. Because if I'm running, hypothetically, radiology department, my budget, my expertise, the staff that I can command under my preview will be radiology department. Anything that I try to optimize will be for radiology. And then I'll be thinking, okay, orthopedics also use imaging services. I'm going to talk to them, but I'm not going to fix the other department for them. It's another budget, another manpower. You do that, multiply within the hospital, multiply within entire healthcare clusters, well, population health, etc. You suddenly realize that things don't really work in a very nice, coherent manner. And the common response I get is, Adam, it's better than before. Yes, if you're on the provider side of things. To the patient, if I go through my entire journey, long waiting time, not so great, fantastic radiology, fantastic cardiology, not so bad waiting time. The feedback, hospital service not good. And this is normal. From the patient perspective, this is what it matters. They don't really care about the technicality of individual stuff. They want the overall grand scheme of experience. This is the problem with system level changes. Okay? This is why it is sometimes so difficult to fix items across the continuum of care. It's like herding cats. Everybody is correct. Each clinical department is correct when they look at it from a discipline, focus angle. You bring it together from a patient-centered care level, you're taking patients' preference into consideration, it becomes a lot more difficult. And for those who are working in a hospital, if you're familiar with closed-loop medication management, where you have actually systems that ensure that whatever the physicians prescribe, the pharmacist dispense, somehow it makes it to the nurse or ward, they feed it to the patient, everything goes in the loop. This used to be a huge problem in a clinical setting because everyone's involved in their own little segment. When you put it all together, who is responsible for the overall process? The physician dispense, the pharmacist, physician prescribe, pharmacy dispense. Then you say, is the physician supposed to overlook this? I got no time, I got patience. So this is exactly the same issue we have when we look at the grand scheme of things. Everyone's involved, no one's in charge. Right? This is where technology comes in. Now the thing is, like it or not, healthcare is a very, very complicated segment, ecosystem, if you will. I don't know how many of you have this experience where you hire a management consultant, no healthcare experience. They come in and then they tell you this is how they've done it in finance, transport, logistics, you name it, anything that's not healthcare, and this is how they've done magic. You try to apply whatever they are saying. It's logical on paper. It makes sense. It just doesn't work in healthcare, right? Next time we have that, we're going to try to decipher, understand this. All business principle, so where all these tools arise from, is the assumption that you can actually create business. All the tools is for you to create business, then you entertain that business. In healthcare, we're trying to get rid of people getting sick. It's the reverse. All the management theory, take it with a pinch of salt. You must actually know how to interpret it in context. So I've been telling people for a long time, because I've been doing digital transformation in healthcare for a long time, healthcare is very complicated. But sometimes it is very difficult to articulate that point across. Thankfully, Minister Ong, on October 18 last year, actually came out and says digital disruption in healthcare are likely to happen as quickly as other sectors. And for a minister to say this, the national papers, amounts to something, it is actually really, really difficult. I'm not going to go through the entire article, but basically, not only did he say it is much more complex, which is true. If you give me enough time, I can articulate this to a layperson, but within 45 minutes, I can't. Not that good yet. Okay, but there are significant policy, regulatory, public confidence issue. We are a conservative industry. We don't go in, make fast, break fast. I hear that from entrepreneurs, hackathons, sort of make fast, break fast. I say, who's going to be responsible when someone dies? You still don't get that, right? So this is where it comes in. Healthcare technology can be used to improve health systems, and we really need to use tech, but in context. So with that, what we need to do is to adopt health system science. This is a very important aspect of healthcare administration, but unfortunately, not many people understand it, or maybe they are studying the non-clinical version of things. Okay, this is, I'll try to very quickly go through some of the key concepts. Now, what health system science is? It is the study and understanding of how care is delivered, how healthcare professionals work together, very important because it's team-based care now, to deliver care that improve patient care and delivery. In other words, health system science can help an organization achieve the quadruple aim. Okay, so what is it? So remember this slide? It has really told you that improving population health requires multiple interventions across systems. We need to fix it from a system level perspective. And in health system science, we have something called clinical microsystems. I don't know how many of you have gone through this before. It's a very interesting topic. After you become more familiar with it, you actually start to scratch your head and thinking that maybe healthcare is not so easy after all. So let me articulate. We have clinical microsystems, clinical mesosystem, and macrosystem. Basically, microsystem is the smallest replicable clinical units that provide care to patient. And when you have multiple clinical microsystems together, the flow is the mesosystem. And collectively, they build up to become the microsystem. That's the very high level explanation for it. So let us look into it in context. Clinical microsystem. Essentially building blocks of larger organizations and ultimately the health system. So if you think back to the continuum of care diagram I drew earlier on, you have multiple units, right? Your prevention and health, your primary care, acute care. Those can be microsystem in the grand scheme of things, but they can be a macro system themselves. Because why? You have radiology, cardiology, wards, and what have you. And if you break down further, each of these clinical departments can be microsystems themselves. So the complexity is actually pretty high. Okay? So the clinical purpose of each microsystem defines the essential parts of that microsystem. And usually, central to the clinical microsystem will be, of course, the patient. And frontline unit that provides care to people. Now, this is where the articulate where patients, family, and care teams need. You can start to apply the patient-centered care model in the clinical microsystem. And it goes on to talk about supporting staff, processes, technology, and frontline. Member processes, digitalization, all the way to people, digital transformation. Now, to optimize clinical microsystem, be it for digital transformation or not, principle remains the same. Digital is just a tool, okay? You have to optimize it from the workflow perspective. Now, the problem is, when I tell people workflow, a lot of people don't understand what I'm talking about. So let's demystify that as well. What is workflow? And if you talk to tech folks, which you have to if you want to do digitalization or digitization, you look at their job titles. Usually when it says architects, systems architect, enterprise architects, they'll say, I'm familiar with workflow. It is the same as use cases. If you look at it from analysts, IT analysts, process analysts, they say, yeah, workflow, processes. Health professionals, usually they say it's PMP. But it's really not the same. It is similar, but not the same. So let's articulate it a little bit further. So for use case, it's defined as a specific scenario, list of steps, interactions between a role and system to achieve that goal. It can be human to human, human to systems interaction, and usually we define use case at the beginning of the project to help understand how the system should be modeled. So when you start on a digital project, they'll say, what is the use case? Because this is the universe of this project. Anything beyond that will be a next phase. Because why? You have to define this. If not, you get scope creep. Your project will get bigger and bigger and you can't manage it. So the example I'm going to give is luggage collection for this use case. In this case, passenger has to clear immigration, proceed to baggage collection point, and wait for the baggage to arrive. If the plane has not landed, not part of this use case. Optimize it, another use case. Okay, so this is use case. Processes, on the other hand, is a collection of related structured activities or tasks that produce a very specific product or service to serve a very particular goal. Usually we use a flow chart or process chart to articulate it. A process begins with a mission objective and ends with the achievement of a specific objective. So my process for luggage collection, that's not to talk about use case, now we're going to talk about process, is that, and you can articulate this in your mind as a flow chart. Plane must first land, if not, go back, wait for plane to land, taxi, park to the correct dot, wait for transportation to arrive, open cargo bay, load cargo bay, deliver, etc. And there's some rules. First come, first serve, VIP gets fragile items, get handled properly, VIP first, bulky items, etc., etc. Now for workflow, it's a depiction of the task, procedure steps, people, systems, input and outputs of information in the business process. Now very importantly, workflow is geographical and culturally specific. No such thing as best workflow. So a lot of time we do a site visit to another hospital and say, hey, they do it this way. Don't copy blindly, because your resources, your expertise, your catchment area is going to be different from what you have. So with this workflow, I've actually drawn this little diagram, which I'm going to explain. I've been told many times I'm a fantastic health informatician, but I would never make a living if I were to try graphic design or drawing. So this is the baggage carousel, okay? And the little blue boxes are luggages. Now, for those of you who have not traveled for a long time, like me, do you remember that when you collect your luggage, there's usually a yellow line. You're supposed to stand behind the yellow line. Who stands behind the yellow line? Naughty, naughty. You're supposed to stand behind the yellow line for a very good reason. Why? The workflow is that if you see your luggage from afar, because we're all at different heights, you can actually go forward and take it easily. Most people crowd around, and then you get in a situation, your baggage, last minute, grab baggage, hit someone. Now, think about this. The workflow, or the use case is the same. The processes is the same. Why is the workflow different? And I'm going to leave this for food for thought. If you guys are interested in finding out why, come talk to me or attend our courses. I'll explain to you, right? But that is clinical microsystem. If you want to fix clinical microsystems, be it departments or clinical units, you have to approach it from a workflow perspective. Fix it from workflow. How about mesosystem? So you have different microsystems which you fix in context. You put together, suddenly the patient journey, not so fantastic. When you look at it from an individual clinical setting, fantastic, best, speedy, great analysis, excellent customer service. Put two things together as part of the patient journey, starts to break down. And the more you go, the bigger flow throughout the ecosystem. It starts to look meh, So to fix, mesosystem really just links all your microsystems together. And this reflects the journey of the patient across the health system. So if you want to improve patient experience, fix it at the mesosystem, okay? And this is where you actually have to apply back two very specific segments of the patient-centered care. Continuity and transition, and your coordination of care, okay? It sounds obvious on hindsight. A lot of people can't piece the two because they don't understand the various theory together, okay? So to optimize mesosystem, which I repeat, is the journey of the patient across the health system, and to them, that is everything. They don't really care you have a fantastic cardiology department, a fantastic famous world surgeon. If it doesn't meet their needs, clinical needs, not relevant, okay? And to optimize meso system, you really have to use technology. No other way, okay? It's just too cumbersome. You have to use tech, okay? And as I mentioned earlier on, a lot of times when we measure quality and satisfaction from a provider perspective, we think, oh, this great department, that great department. But really, look at it from a patient perspective, patient-centered care. Their overall experience is not segregated by clinical departments, okay? Very important. Once we get this, we can start to improve things across the continuum of care. The last bit I'm going to talk about is the macro system. So we have micro system, individual units, and then you put them together through the meso system, it becomes the micro system. Now, the philosophy is no health system can be better than a small system. So if you want to optimize macro system, you first optimize the micro system and the meso system. Then things will flow in tandem, right? With that, I'm going to wrap up because I've been told less than 10 minutes. That was like 5 minutes ago. So the quest to achieving the quadruple aim of improving population health, reducing cost of care, enhancing patient experience while improving provider satisfaction really requires organization to apply these skill sets to design patient-centered flow supported by digital and industrial 4.0. Do not throw technology up front. Fix your policy, processes, and culture because this is a social initiative. Health is social, okay? Then effect system-level changes across this very, very complicated continuum of care setting as opposed to initiating multiple silo incremental improvement that doesn't gel well when you put together on hindsight. With that, I end my presentation, and as mentioned at the beginning of the talk, if you have any questions, please kindly scan and submit them. Do we have any questions? That's it, that's the applause. Thank you. Any questions? What do you think are some of the crucial healthcare digitalization trends going on? There's so many. Crucial. Depending on which lens you're looking at, if you want to solve diagnosis shortage of medical doctors, obviously AI is going to help. AI can help, but in a controlled setting. Okay, a lot of people think that it's not true. Yes, you can. If you are clear about your clinical intervention, you can apply AI, train the data. If you're talking about supplementing manpower, robots is there to help, nurses. If you talk about community care down to aging population, robots is there as well. But one of the other very important initiatives that for health informaticians we'll be working on for the longest time is to ensure that we can actually share and use data. That has been a very difficult battle. Yeah. Can you share your views on Healthier SG? I still want to work in Singapore, so I think it's a great initiative. I'm actually public health trained. So when I look at Healthier SG, and there's this part on capitation, which is actually value-based care, and you look at the trends of what we have been doing in Singapore for the past 10 years or so, is good improvement, but it takes time. A lot of people complain that, hey, why can't we do it like that? Remember, you're dealing with human beings. A lot of medical doctors, a lot of nurses, right? They're all very, very busy people. And to them, from their perspective, a lot of times we are the nuisance, okay? So there's, I'm doing my job very well. Why do you come and make me implement another electronic medical record, make me do documentation, go away, okay? So that's my view. I think it's a great initiative, yep. What is the biggest reason for care remaining fragmented after a few iteration of regional health care system? It takes time. It takes time. I think from the 6 to 3 cluster, a lot of experimentation was in place. It was a nightmare from an administrative perspective, but you can see evolution and growth. And the ecosystem became more refined when it becomes 3 cluster. On hindsight, it's always, yeah, I think it's a good movement. Through the process, very painful when you're trying to, when you're in the midst of it, but now you're looking at it, I think it was great improvement. Biggest reason, again, we're dealing with humans, very tough. Yeah, don't know how many of you tried change management in healthcare. It's, yeah, tough, yes. Any other questions? Able to describe the complexity of transformation in healthcare? Most digital transformation projects fail, accept that. be it in healthcare or not. So you really have to get someone who actually understands clinical workflow to do transformation in healthcare. Finance, logistics, transportation, very tough. No one's going to die for any hiccups. Healthcare, not so much, and you know you're affecting patient's experience in care, provider end and patient end. That's the complexity. Yeah. Why does it seem that local hospitals are advancing slower than hospitals? That's not true. We are advancing. We are actually advancing pretty well. So I do projects across Asia, and my last few years in the Middle East before COVID. And I honestly think that Singapore has done a very decent job. It's not the best job out there. No one has it perfect, but we have done a very decent job. Can it be improved? Absolutely. If you have pain, if you feel pain in whatever work you're doing right now, and you think you need help, just call Adam. Okay? We do consultancy services as well. Yes. If microsystems can all be seen as meso or macro, why would digitalization look like starting? Why and how would digitalization look like starting at a microsystem? Can digital be enabler then? Definitely you can do digitalization on a micro level, microsystem level. It's just that if you were to do a brand new intervention, do not try to repeat whatever you do at the analog setting straight on the digital setting. Have some thoughts about it. Digital has many advantages, but replicating the same is not going to help you. You must actually think of what are the advantages, understand the tech that you're using, understand the clinical workflow, think of the processes, etc., and then implement it. So for those who have a computer science background, there's this term that we call it GIGO, G-I-G-O. It stands garbage in, garbage out. So when you want to automate stuff, if it's a bad processes to be with, it's not obvious on hindsight, because if you do it analog, it take you days. You computerize it, you have all the advantage of computing. They accelerate, calculate, compute, and then you see garbage result upright. So you actually have to optimize underlying processes, etc. How do we best manage overlaps in the care ecosystem? So many fingers, hands, legs involved simply because it's so complex. Health in general, care in general is complicated because we try to apply a lot of concepts we have in other industry into health. That's why we have such segmentation. In reality, it's really just keeping the patient or the person healthy, right? So if we do everything properly, which is through public health, you have the Healthier SG initiative, and we should ideally not be taxing the healthcare system that much. What do you think can be done to strengthen partnerships between acute and community care providers? Well, that's a very big question. I've got 1 minute. Whoever sent this can go and talk to me on the after this session. Yeah. Any other questions? In your view, how challenging is it to reconcile between clinical workflow experts with digitalization experts? Very tough. If you have a pure clinical trained professional, they actually don't understand whatever tech guys are saying. The logic is different. How we think is different. You really must get people who actually understand both aspects of the spectrum. So again, if all things fail, come to us at NUS. We'll help you. Right. With that, I've just been giving the signal, end of time. But please, if you guys have any questions or you feel that the answers were not satisfactory, feel free to reach out to me. I'm more than happy to have a conversation with you. Just buy me coffee. So please help us fill in a post-event feedback form as well so that we can improve. With that, I thank you so much for your attention. Thank you.